Good morning, my name is Raj Masia. I work for Potomac Highlands Guild as Health and Wellness Coordinator. I'm a CPR First Aid instructor. And for those of you who are in the unique situation of the current COVID-19 restrictions on performing the full CPR First Aid AED class, this module today will be the hands-on demonstration that we're able to show you how this is done. Hopefully we can answer your questions, and this will fulfill your requirements for your CPR First Aid training to work for Potomac Highlands Guild, either directly or as one of the contract agencies working for us. So first of all, we're going to talk about CPR First Aid in an adult. In 1985, prior to 1985, CPR First Aid used to happen mostly in the back of an ambulance. The ambulances looked like a hearse, and it wasn't until 1986 when ambulances became more technologically advanced. They look like the current box that we know now, and the whole algorithm for CPR First Aid changed. One of the things that you guys will remember in assessing a patient, for an adult patient, what we used to do was we would shake the patient. Then we would look, listen, and feel. We'd look for, is the chest wall rising? We'd listen for air coming out. We'd feel it on our cheek. We would then take two fingers and we would check for a pulse in the carotid artery. We no longer do that. So American Red Cross has removed this. Why did they remove it? Because it took an excessive amount of time. Most people were like, oh my gosh, am I feeling a pulse? Am I not? Is he breathing? Is he not? And precious minutes went by. So we no longer do the shake the person. American Red Cross now recommends that we tap the person on the shoulder, say their name if we know it. If not, hey buddy, are you okay? Are you okay? If there's no response, we no longer look, listen, and feel for air. We don't check for a pulse. If we spend no more than 5 to 10 seconds in assessing them, if they're not waking up, if it appears they're unresponsive, we start CPR. One of the other things that has changed since 2012 is we previously used to do chest compressions and breaths. Chest compressions and breaths. So I'm going to ask you this question. When we are just sitting in a normal room, normal environment, breathing in, breathing out, what is the air, what is the gas that we are breathing in? That is oxygen. What is the gas that we're breathing out? That is carbon dioxide. So when I give breaths to someone, I'm essentially blowing carbon dioxide into them, which we know doesn't save lives. What does save lives is doing good compressions, which has the effect of not only circulating blood, but also when we do good compressions in the correct way, it causes the diaphragm to move up and down. When we push in, it allows the diaphragm to contract, pulling in fresh oxygen. When we let off, it allows CO2 to come out. So we can actually perform better respirations for a person by doing what we call hands-only CPR. How do we do CPR? So we've assessed the patient, we spend no more than 5 to 10 seconds, and we immediately go into performing CPR. How do we do that? We take both of our hands, we interlace them like this, we interlace our hands, and we're going to use the heel of our hand, and we're going to put it right over the sternum, center of the chest right here, this breastbone. We're going to put it right here. Now you want to make sure that your shoulders are over. Your shoulders are over so you can use the full weight of your body, and we're going to push down. And how do we do this? The rhythm should be fast enough that you can count out the numbers after each compression. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11. So keep doing chest compressions at this rhythm. On this mannequin, you know you're doing it right when you can hear the clicking sound. One of the other really important things is you want to make sure that the person is on a firm, hard surface. Can you do good CPR in a waterbed? No. Can you do it on a really soft mattress? No, you can't get the compressions that you need. One of the important things I remember when I was a straight out of medical school, and I was just starting my training as an intern, and one of the very first days I was on call, they gave us a giant pager to carry. This was the code blue pager. It's my first week at work, and I'm scared to death that this thing is going to go off. Sure enough, one fine day, 4 o'clock in the morning, pager goes off, code blue, ICU room 32, and I'm tearing up there as fast as I can. I get there, and in each hospital bed, you'll notice that at the head of the bed, there's a plastic board, and the job of this board is to come off, and we slide it underneath the patient so it creates a firm, hard surface so we can do CPR. So I knew as a brand new intern, this was my job. Pull this off and initiate CPR. So in hospitals, there's another resident who maybe has 1 year more training than I did, and somewhere in the hospital was a real doctor who was asleep and we're never supposed to wake him up. So the code blue pager goes off, I run up, I grab this thing off the head of the bed, I know I gotta slide it under. As I did this, as I pulled it off, the second year resident who had just run into the room, I hit him on the side of the head. He went unconscious, bleeding from his head, patient's unconscious, and the nurses were just laughing at me. But that made me remember, patient survived, the resident survived. You always have to use a hard surface. If you're at home, pull the person onto the ground. Get as much assistance as you can. So when we do chest compressions, we try and count it out, sound it out in between 1 and 2 and 3 and 4 and 5. That's the rhythm that we use. And we want to make sure that we're going all the way in, all the way up. Can you break ribs during this process? Yes. If you're doing CPR on a 90-year-old woman, there's a possibility you may break ribs. Should that stop you from doing good CPR? No. At the end of the day, if we break ribs, those can be repaired, they can be fixed, but we want to sustain life. So good CPR is essential. If you remember nothing else, just remember this: push hard, push fast. Moving on to an infant. So in an infant, very similar, an infant who is unconscious, unresponsive, we used to, shake the baby. We don't do that anymore. So all of our curriculum is through American Red Cross. So American Red Cross recommends we tap the foot of the baby. We tap the foot. We no longer are doing look, listen, and feel. We're not trying to check for a pulse, which, as many of you know, can be very difficult in an infant, and that wastes precious time. So we jump right in. No more than 5 to 10 seconds of assessment. Baby, are you okay? Are you okay? No response. We jump in, we start performing CPR. Do we give breaths? No, we don't. Remember, we're blowing in carbon dioxide, which doesn't help life. So how do we do this? We use 2 fingers. 2 fingers in the center of the sternum. We put one hand on the head to stay on the forehead to stabilize it. Otherwise, babies have a tendency to collapse the neck and no air can get in and out. So we want to put a hand on the forehead, neutral position, so the mouth is straight up. 2 fingers on the sternum. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8. And this should be our rhythm, counting in between. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8. When do we stop CPR? When do we stop CPR? We stop CPR under some conditions. Number 1, the person wakes up and says, "Thank you. Thank you very much. You saved my life." Or a second provider comes over and he takes over while you rest. For those of you who've actually done CPR before, it is exhausting. It is absolutely exhausting. Unfortunately, I've had to do it many, many times in the ER, and all of us are drenched in sweat, and we have giant teams of people circulating, and it's very, very tiring. So if someone else comes up, let them take over. If EMS comes, we turn this over to them. Remember, we're a cog in the wheel of the chain of survival. EMS is the next step. So we turn it over to them. If conditions become unsafe, for example, I'm doing CPR in this building and suddenly fire breaks out over here, condition is unsafe, I can stop CPR. And lastly, the reason I can stop is if I'm too tired to carry on. If it's just me and this guy in the top of Dolly Sods, and I've been doing CPR for 1 hour and I am exhausted, then I have satisfied all the conditions and I can stop. So we want to make sure that we, do our best efforts with chest compressions and trying to get help. So we want to make sure that we have, prior to the initiation of CPR, someone is called you call 911, you get an AED, you get a first aid kit, so we make sure we have help coming. Moving on to our next topic will be choking, demonstration of choking. So choking happens most often in adults. Normally there's a tube in the front. If everybody feels the front of their neck right here, this is our airway. It's rigid, you can feel these rings. And behind it is the food pipe. And the way we were made, we have a little flap valve, which when we are breathing, it covers off the food pipe. When we're drinking water or chewing food or swallowing something, it covers off the opening to the airway. So no, those two never mix, and they're right next to each other. So if someone is eating something, eating a piece of steak, and a joke is told and I start to laugh, that could trigger a response where now it can go into the airway and the airway becomes blocked. In small infants, they get usually obstructed on small things like a small toy or a whistle or a piece of food that's too big that they haven't chewed up. People who are choking, if someone says to you, "I'm choking," they're not choking. The definition of choking is no air in, no air out. The universal sign for choking is 2 hands around the neck like this. And this is one of the most satisfying interventions you can do, because almost 90% of the time this is successful. Bystanders are successful in dislodging something stuck in the airway. So how do we do this? Remember, the person is going to tell us he's going to have hands around his neck, so we want to do a couple of things. Number one, this person is probably freaked out because no air in, no air out. They're in a panic mode. So we want to tell them, "Hey, I'm Raj, I'm trained in CPR first aid, I'm going to help you. I need you to do what I'm telling you." They'll nod their head in assent. So the first thing we want to do a series of 2 things. One is back blows, and the second is abdominal thrusts. And we're telling them what we're going to do. So we're going to ask the person to bend over at the waist. We want their head down because we want gravity to assist it in coming down. So we hold them from the front. Right between the shoulder blades, we're going to use the heel of our palm. And we're going to use a lot of force. Try and jam this out. And we're going to do it 5 times. 1, 2, 3, 4, 5. If it doesn't come out, we're going to bring them back up. And we're going to go right here between the belly button and where the ribs start, where the sternum starts, this area. We're going to take our fist, thumb side against here, wrap a hand around it, and we're going to pull hard in and up 5 times. 1, 2, 3, 4, 5. A lot of times this diaphragm pressure will dislodge it. If it doesn't come out, we bend them over again. 1, 2, 3, 4, 5. Doesn't come out, we come back to abdominal thrust. 1, 2, 3, 4, 5. And we're pushing hard. So one of 2 things will happen in the process of us delivering back blows and abdominal thrusts. Either this will come out and the person will say, "Thank you so much, you saved my life." Or due to lack of oxygen, because the airway is blocked, he will go unconscious. If he's unconscious, what do? We start CPR. You call 911, you get an AED, you get a first aid kit, and we start CPR. We're not delivering breaths. They used to ask us to put our finger in there and do a finger sweep. We don't do that anymore. That can just further dislodge things and actually trigger a vomiting reflex. We don't do any of that. We're going to continue to support breathing and try and dislodge this using good chest compressions. How do we do that? One hand, fingers interlaced, hard surface, directly in the sternum. Move our shoulders over so we can use our weight of our body, and we push down. We push hard and we push fast, counting in between. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8. We keep doing this till either the person wakes up, or a second person comes up to help us, or EMS arrives, or we're too tired to proceed, or the scene becomes unsafe. How about with an infant? With an infant, it's a little different. This is the only time we're going to be actually sitting down to do something. So an infant who's choking is probably not going to be able to tell us. You'll see they're turning red, then blue. So how do we do this? We want to get our thigh lined up with our forearm, and we want the baby's long axis of the body lined up with our forearm and our thigh. So we want to support the face You want to leave the mouth open so that stuff can come out, whatever's causing the blockage. We go between the shoulder blades and we deliver 5 back blows. Head is down. We want gravity to assist us. 1, 2, 3, 4, 5. Didn't come out. I'm going to use the baby on the opposite thigh, arm lined up, thigh lined up, and I'm going to use 2 fingers, same place we do CPR. 1 and 2 and 3 and 4 and 5. Didn't come out, flip them over. 1, 2, 3, 4, 5. Didn't come out, flip them over. 1, 2, 3, 4, 5. And we keep doing cycles of back blows, chest abdominal thrusts until either it comes out or the baby becomes unconscious. If they're unconscious, what do? We start CPR. Hard surface, you call 911, get an ambulance, get an AED, get a first aid kit, and I start CPR. We don't put our fingers in there, we do none of that. We put one hand on the head to stabilize the airway, 2 fingers, 1 and 2 and 3 and 4 and 5. And we keep doing this till either EMS arrives, assumes care from us, someone comes to help us, scene becomes unsafe, baby wakes up, or we are too tired to proceed. So that's sort of our algorithm for CPR first aid combined with choking. So the next thing we're going to do is an AED. So automated external defibrillators look like this. And this is an absolute life-saving device that is simple to use, and I'm here to tell every single one of you that you can use it. So what is the principle of the AED? Now our heart has electrical activity in it. Normally the heartbeat looks like this. It beats around 72 beats a minute. The top chambers contract, lub-dub, 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 lub-dub. When someone goes into cardiac arrest, if you're watching a show like ER on TV or you're watching the movies, and when they show somebody who's dying and suddenly the camera angle will flip to the cardiac monitor, what do they show most of the time? They show a flat line, right? He flatlined, it's over. Whereas in reality, when someone goes into cardiac arrest, instead of beating nice and regular like this, it'll beat 200 to 300 beats a minute, very irregularly in a pattern called VFib or VTAC. So instead of pumping like this, lub-dub, 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 it starts going brrrr, so fast that no blood can get in, nothing can get out, and the person basically goes into cardiac arrest. When this is going on, ventricular fibrillation or ventricular tachycardia, the best way to get them out is to use an AED. Now, AEDs prior to 1985 used to be very large boxes that were just in the ER, and an ER doc would utilize that to defibrillate somebody. In 1985, the American College of Emergency Physicians said, you know what, people aren't really surviving this. For example, if you go into cardiac arrest in Pendleton County, in Franklin, back in the day, they would load you up on this ambulance, which looked like a hearse, drive as fast as they could till they got to the nearest hospital where an ER doc would then try and defibrillate you. Most people did not survive that. So in 1985, they said, let's train EMTs and paramedics on how to use a defibrillator and let's put them on every ambulance. So that really changed the survival rate. And then in the year 2000, they said, let's take this one step further. Why don't we make AEDs, let's put them in the hands of millions of people. Let's put them in Walmart, in airports, in schools, in colleges, in shopping malls. Let's saturate the country with these things. And since that has happened, millions of people have been trained in how to use an AED, and the survival rate has gone from cardiac arrest from a rate of about 39 out of 100 people surviving to now it's almost 61%. So we nearly doubled the rate of survival. So what does an AED do? It looks scary, but it's not. It's very, very simple. When you first open this up, and maybe in a glass container, break glass, open the door, find the AED, they all look the same. You open it up, you're like, oh my gosh, what do I do with this thing? So it tells you, the very first thing is pull. So you want to pull this open, and it says, what do I do next? Place. What am I placing? Oh, these pads. and the pads are inside. This is a real live AED, so I'm not going to take it apart. Where do I put the pads? It shows me exactly where to put the pads. Well, where does this one go? Right here. Where does this one go? Right here. Okay. What do I do next? Well, then it tells me the electric shock button, I turn it on. So I turn it on.
Analyzing rhythm.
Analyzing rhythm. So the unique thing about this is it delivers a shock in a millisecond. So the shock goes in, goes out. And most of the time that can interrupt this rhythm and bring it back to normal rhythm. So, but there's some things we need to be careful about. Number one, if it's the middle of winter and the person has clothes on, every AED has this kit. So remember, we want to wear personal protective equipment. So there'll be a pair of gloves in here. There'll be scissors, so you can cut the shirt off. If they're wearing a bra, you want to cut right through it, because this has to be on bare skin. Has to be on bare skin. And these pads are sticky. They peel off. You put one here, and you turn it into the machine. The machine talks to you and tells you what's happening. So let's suppose this is someone who was in cardiac arrest. I was doing CPR. Someone rolls up with an AED. I've got an AED. What do we do first? So we want to go through the steps. Pull it down, place the pads on, plug it in. We cut the shirt off. What do we do next? This tells you exactly what to do. So someone's doing CPR. We put the pads on.
Analyzing rhythm.
It'll tell us. Analyzing rhythm. Everyone stand clear. Everyone stand clear. Everyone stand clear. Nobody touch. Nobody touch. Stop CPR.
Shock advised. Charging.
Shock advised.
Everyone stand clear.
So it starts charging,
Everyone
and
stand
the
clear.
light flashes.
Push the shock button.
Nobody touch. Nobody touch. Nobody touch.
Shock delivered.
Shock
Begin
delivered.
5 cycles of CPR.
Begin 5 cycles of CPR. So it's very difficult to get this wrong. It's so easy. You put the pads on, plug it in, turn it on. It starts talking to you. It tells you stop CPR, analyzing rhythm. Everybody clear. So you want nobody touching, nobody touching, nobody touching. I have in my life accidentally shocked my brother one time when we were both working on someone, and it was not a pleasant sight. So I want to make sure nobody's touching. The machine will tell you stop CPR. It'll tell you shock advised. When that happens, you want to look for the lightning bolt button, and you just push it. It'll start flashing. You press that button, and in a millisecond, it will deliver electrical current that can interrupt that. The machine then tells you, what do I do next? I press the button, it gave the shock. Continue CPR. Okay, jump back in. You got one pad here, you continue CPR. Soon the machine will tell you, stop CPR, analyzing rhythm. Stop CPR, everyone clear, nobody touch, nobody touch, nobody touch. Shock advised, deliver shock. This light will start flashing again. I press it, delivers a shock, and it tells us again, continue CPR. We keep doing CPR shock until when? EMS comes. If EMS rolls up, what they will typically do is they will leave the pads and they will take this off of yours, plug it into theirs, and load and go with the patient. So this machine is very, very difficult to get wrong. I'm here to tell you that everyone can use it. Everyone can use it. It's very, very simple. Just follow the steps. Put it on. Couple of things with an AED. You don't want to use this in the rain, if it's pouring rain and you're outdoors, because it is an electrical current, so we don't want it in the rain. If somebody's buried in snow, you want to try and pull them out of there and make sure that the surface is not wet. You don't want to lie them on a metal surface, like metal bleachers or something, because that could conduct electricity, so you want them on a non-conducting surface. Because we are doing CPR, we also want them to be on a hard surface. And we deliver the shock until either the patient wakes up and says, thank you, EMS arrives, someone comes to take over, and you can alternate CPR and shock, or the situation becomes unsafe, either fire or smoke, or you become too exhausted to carry on. So the principles are the same. In a baby who goes into cardiac arrest, we use this very similarly. So again, we want to get the AED, and first thing we want to do, have the chest exposed. When we pull these out, it's going to say one goes here. Wait a minute, these are too big for the baby. How do we do it in a baby then? We put one on the front, one of the pads on the front, one on the back. We take the wires exactly the same as we would on an adult. We plug it in, we turn the machine on. We're doing CPR through the pad until it tells us stop CPR, analyzing rhythm, everyone clear, shock advised, deliver shock. This lightning bulb will start flashing. On the real AED, it'll be this one right here. It'll start flashing. You push that button, in a millisecond it delivers this current to try and interrupt that, return it to this, and it'll tell you continue CPR. So again, one hand on the head, stabilize the airway, 2 fingers in the chest, and 1 and 2 and 3 and 4. We keep doing this until it tells us stop CPR, analyzing rhythm, everyone clear, shock advised. We go through the exact same process of delivering shock. So shock, CPR, shock, CPR, shock, CPR. So that's the only difference in an infant. What about in the situation of somebody who has a pacemaker put in by a doctor? It's usually right under here. What do we do in that situation if someone has a pacemaker? Well, we don't want to put this on top of that because it may not deliver the full shock. So we can put one on the front, one on the back, just like we do in an infant. We just want to make sure the 2 pads are on there, separated from each other, not touching each other. Can I use this in a pregnant woman who's pregnant? Absolutely. Will the baby get shocked? Yes, but we have a dead mom and a dead baby versus both of them living by disrupting this lethal arrhythmia. Can I use it on somebody who has metal in their shoulder? Yes, I can. So again, at the end of the day, this is a life or death situation. We want to administer shock as soon as possible. All right, moving right on. The next thing that we want to look at is stroke. And for those of you who've taken the online class, who maybe received this manual, so what is stroke? We want to talk about stroke for a second. So stroke and heart attack are very closely related. So this is a model of your heart. Actually, we can draw it on here. If this is your heart, there's 4 chambers. Right atrium, left ventricle, right ventricle. And we have blood vessel called the aorta, a big vessel that curves like this. And it has 3 main branches that supply the heart. Sometimes we can get a blockage in one of the arteries, and that causes no blood flow to come to this area, and this area starts to die. And most of the time, the person who's experienced this has normally a blood vessel. If we took one of these blood vessels and cut it open, what would it look like? It would look nice and smooth in a newborn baby. As we get older, we have high cholesterol, we have high blood pressure, we have diabetes, we have high triglycerides, we never exercise. Plaque starts to build up inside the blood vessels. And from years and years and years and years of not doing anything, sometimes this can just become to the point where all you have is just a tiny slit-like opening right here. Everything else is blocked off. And once that little slit becomes blocked and no blood can go through, that is essentially what causes a heart attack. Heart attack, most commonly, symptoms are pain in the chest, going down the arm, shortness of breath, and sweating. And many of you may have seen the pink ribbon campaign. The pink ribbon campaign, what is that for? That's for breast cancer awareness in women. There's also a red ribbon campaign. What is a red ribbon campaign for? You'll see people wearing these ribbons. It is for women's heart health awareness. And they did a massive study a few years back looking to see who survives heart attacks. And they found that men were surviving heart attacks way more than women. And they found that the mortality rate, the death rate for women from a heart attack was much, much higher than men. So when the investigators went and started to study this, they said, let's look at why are women dying of heart attacks at greater rates than men. So they took these these records, hundreds of thousands of records of women who had died of a heart attack. And they said, okay, they died on this day. Let's go back and see when they first came in, what did they complain of? So they looked at the men. The men all had almost the same thing. Left-sided chest pain, going down the left arm, into the neck, shortness of breath, sweating. When they looked at the women, very few of them had left-sided chest pain. Most of them had weird symptoms. Upper abdominal pain, pain between the shoulder blades, pain on the right side of the chest, pain in the right shoulder, only jaw pain, only nausea, only sweating. So because these symptoms were not typically related to having a heart attack, maybe that's the reason why the care was delayed and they didn't get the care that they needed and they died. So the Red Ribbon campaign is to raise worldwide awareness that symptoms of heart attacks in women are dramatically different than in men. So if you're home and grandma starts complaining of pain in this area, maybe she says, I have pain here, I'm nauseated, I'm sweating, that could be a heart attack. Encourage her to go to the ER. Explain these things to her. And you know, most women, unlike men, are gonna do what? Are they gonna rush to the ER anytime they have jaw pain or mid-abdominal pain or pain in their back? They're not. Women try to ignore these symptoms and say, you know, it's probably just heartburn. I probably just pulled a muscle. So it's real important that we, as family members, as community members, try and link those people. If we're dealing with a client who has risk factors like high blood pressure, diabetes, high cholesterol, family history of heart disease, history of smoking. If someone has risk factors and has these weird symptoms, right-sided shoulder pain, mid-back pain, nausea, sweating, get them to the hospital so they can be evaluated for a heart attack. So that's one of the real important things. And the second thing we want to talk about is stroke. So stroke is what? Stroke is a brain attack. Just like we have heart attacks, stroke is a brain attack. So if this is your brain, this is your brain, and just how the heart is supplied with blood vessels. There are large blood vessels that come out of the heart, enter the brain, and there's three main branches that supply everything. So if you have a blockage right here, then anything that is downstream from that is going to be affected, and ultimately without blood flow will die, and that is called a stroke. And the same processes that happen in a heart attack, blood vessels getting blocked from cholesterol, triglycerides, lack of exercise, so you only have a tiny, tiny slit-like opening for blood to go through. Again, that's what causes a stroke. So what are we supposed to do for stroke? Our American Red Cross First Aid CPR curriculum wants us to take certain actions. And the algorithm is called FAST. And FAST saves lives. So the F in FAST stands for face. So the face, what happens to people in a stroke? You'll notice one side of the face is maybe drawn over to one side, recognizing that their face looks different. Number two is arm. So if we suspect someone's having a stroke, we ask them to raise their arms. Typically, people, instead of being able to raise both arms, someone with a stroke may not be able to lift one arm. So now they have face deviated, one arm not lifting. The S stands for speech. We ask them to say something. So we see the face drooped over, they can't lift an arm, and we're like, Grandpa, say the sky is blue. It may come out, the sky is, he may not be able to make the words. He may be able to make no sound at all. So speech is impaired in stroke. And lastly is time. T stands for time. There's a 3-hour window. So it's real important that we note the time that the symptoms started. There's a 3-hour window to get treatment for a stroke. If someone is transported from the time of the onset of a stroke to a stroke center within 3 hours, they can get a clot-busting medication through their vein that can open this up and allow blood flow to go to the part of the brain that's not getting it, and the stroke can be reversed. So it's real important that everyone know. This happened at 10:15, so we tell EMS 10:15. They're telling the ER doc, who's telling the stroke center 10:15. So that's when our window starts. So if there's going to be a helicopter transport, we all know that's the clock that we're racing against, is to get to the stroke center. So FAST, that is the most important thing they want us to recognize for stroke. I know that was a lot of information in a very short period of time. If you want to come in one-on-one with me to demonstrate this, to work on it, if you have any questions, you can call me, text me. My email is rajm@phgmail.net, or you can call that number if you have any questions. Thank you very much. Hope you guys do well. Be safe in this COVID-19 season.